So why are older adults more vulnerable to this process? And some of it may be self-evident, but surely we know that there are iatrogenic complications. That's why Medicare, for example, created the so-called never events that basically hospitals are not paid or they're penalized for things like catheter-associated infections or falls with hip fracture or injury in the hospital. So they won't get paid for that, and if they meet a certain threshold, they actually are penalized for those accumulated incidences in the hospital. The other problem with older adults and their vulnerability is that they have multiple chronic conditions. Basically, it's broken down into 1/3 have 1 or 2 chronic conditions, and then older adults have 3 to 5 multiple chronic conditions, another 33%, and then finally, fully 1/3 have 5 or more chronic conditions. And so you can imagine with those multiple chronic conditions that there's complex therapeutic regimens. And if you, for instance, have 10 or more medications, there's a 100% chance that you're going to have a drug-drug interaction in that instance. We also have to deal with functional decline. So just, again, I call it getting your legs back, but just an ability to transfer from bed to chair or from bed to standing could be quite an issue. And I found that, for example, patients that were transferred from the hospital to the nursing home setting could barely lift 2 pounds of weight in their arms. The other complications are delirium and dementia. So it turns out that if you have unresolved delirium from the hospital setting, that there's a high mortality rate 1 year after discharge. So there's about a 50% mortality rate in older adults that have unresolved delirium upon discharge from the hospital. Also, you have to consider the adverse drug events. A lot of times these medications are new, and these delayed reactions, for example, might not occur for weeks to months after the medication started. Such examples include statins that may cause myositis or myalgias, and you may not see that for several weeks to months until after the start of the medication. Poor social support may be obvious, but a lot of times we attribute higher capacity for older adults to take care of themselves and their self-care than they actually can. And just be very cautious of the older adult who has a higher education. So a lot of times college-educated older adults may give you the impression that they have more self-care capabilities than they actually do, or they just may have this inclination or predisposition that they don't want to bother family members and they want to stay independent, but don't lack the judgment to really to see that they really do need assistance. And then finally, some people call malnutrition the fifth geriatric M of what matters: medications, mobility, and mentation. So malnutrition will affect about 15% of the population, and probably a little bit more percentage-wise of the recently discharged patient from the hospital, because as it turns out, there's been studies that have shown that hospitalization basically is associated with a starvation diet. There's just not enough calories that are included in a regular hospital diet, and it turns out that older adults need more protein than middle-aged patients, and that's often overlooked. So contributing to suboptimal transfers include patients' issues, as we saw in our initial case where the gentleman that needed wound care and was diabetic just wanted to go home. You know, it was just matter of fact, and he didn't want to have anything else to do with it other than he was going home, and he was very fixated on that. And indeed, people are fixated on never wanting to go to a nursing home, and so you really deal with a wide variety of attitudes about long-term care, and some of them justified and others maybe not so much. But there's also system issues that we need to address, and I want to delve into that a little bit more. in addition to talking about patient-specific issues that can cause a suboptimal transfer. So some of the risk factors for these suboptimal transitions, particularly from the hospital, include advanced age, so socioeconomic considerations. If they already have a functional impairment, that's going to be a contributing factor to suboptimal transitions. If they are not real good at self-management of their chronic diseases, so for example with congestive heart failure, if they're not able to weigh themselves daily, that's going to really limit their ability to modulate, for instance, increased use of diuretics to get rid of increased water weight. The living alone is a big risk factor. I call those individuals the Lone Ranger, if you're familiar with that genre. But basically, a lot of times these folks just don't have the social support to really optimize their recovery at home. Sometimes the transition to home care services is delayed. It doesn't occur as quickly as you would hope, and for a variety of reasons, and that could be pose a problem. And in fact, if you do order home care services, you need to indicate to the home care agency how soon you want the individual patient to be seen. Prior hospitalizations and long lengths of stay are also future risk factors for both poor transitions and for future hospitalizations. We often say that the prior hospitalized patient, if re-hospitalized, sometimes we call them frequent flyers, and we all know and have experienced patients like that who just keep going through like the turnstile back and forth to the hospital without necessarily getting much better. In terms of, excuse me, I just want to, there we go, we got the slide deck going properly here. So in contrast, the system level risk factors for poor transitions include things like, as I mentioned, a high hospital admission rate. If there's no good or poor discharge education, again, maybe not enough time, let alone the quality of the education may be a predisposing factor there. Certainly insufficient communication across care settings. So oftentimes we find hospitalists will do a discharge summary. Perhaps they do it in a timely fashion, and they've got the job done, right? So they don't call the primary care physician, and that would be desirable. That would be a higher level of communication, particularly if they contact the primary care physician in the nursing home setting, for example, where certain issues may come up. I just want to point out that a lot of times older adults will experience delirium. So up to 33% of older adults may experience some form of hypo or hyperactive delirium, and it's never documented in the medical record. And so it's important to know whether they had delirium, because if somebody is discharged from the hospital on risperidol or Haldol, you can kind of presume possibly that they had delirium, but who knows? Maybe they were put on an antipsychotic for depression in the past. So there's lots of what ifs that are associated with transitional care and should not be left to make an educated guess on that. And so again, good communications are important across settings. So some of the barriers that we need to consider are diversity of patient needs. A lot of these are based upon social determinants of health, certainly economic resources. So somebody that is in a wealthier category might be able to afford 24/7 nursing care, for example, that may not be supported. Well, 24/7 nursing care is not supported by Medicare for sure. And not many insurance companies, unless you have concierge service or something of that ilk. The communication barriers, certainly we've recognized these when there's a delay in the discharge summary process, although quite honestly I think that's improved since the electronic medical record implementation. A lot of times the hospitalist's knowledge of transitions care may be somewhat sparse, and it's with that mentality of putting the fire out and get them out. Quick transitions of care, and quite honestly, hospitalists are put under a lot of duress precisely because of that reason. The hospital's at 110% capacity, and they just got to go through high output basically. And then the other problem is just getting a hold of the primary care provider. And I can sympathize with a hospitalist who has to identify the primary care provider. Just looking at my geriatric consults in the clinic, I know that there's a lot of the patients that have a physician attributed to their clinical care, but in a lot of the cases, that particular physician has either left the healthcare system or is not seeing the patient anymore. They were transferred to somebody else, and that's not reflected in the electronic medical record very expeditiously. So that's a problem. Let me see if I can get this slide a little bit better. Looks like I'm not. Sorry about that. There's a little offset here. So what is effective transitional care? Well, certainly there's a timeliness to it. You want to basically try to align the care with what matters to the older adult within the context of their decisional making capacity, right? We have to remember our illustrated case in point where the older adult was not able to handle himself in the home setting. But basically, I think the bottom line is that if you apply the geriatric 4Ms of aligning what matters to the patient with their care plan, looking at the medications, so medication review, also looking at their mobility plan, plan of care, as well as what their mentation status is. So are they leaving the hospital depressed, or cognitively impaired, or still delirious? I mean, my most incredulous observation is somebody who's discharged from the hospital because the hospital said, well, I saw them in the morning, they were doing just fine. And then by the afternoon, they're confused, loss of attention span, and back in their delirious state. And that's just classic delirium, right? It goes, it ebbs and flows like a roller coaster. There'll be moments of lucency, followed by moments of confusional state. So what works well in transitional care? And basically, this includes good education. So we want self-efficacy and self-management plans for the older adult. This is huge here, this caregiver training. That shows huge impact, particularly in the cognitively impaired older adult. So there should be some form of caregiver training, whether that be online or through diligent efforts to get the caregiver either as a post-hospital healthcare coach or other techniques. That's got high impact with low cost. In terms of care coordination, it's important to have within the healthcare system the individual being routed to various either specialty care, but certainly primary care. And I would also advocate, if you have a geriatrics program, to include in that process of transition the geriatrics team, because it's there's really strong evidence that geriatric care involvement at both ends of the care spectrum, so during hospitalization and post-hospitalization, really has a very, very strong impact on improving quality outcomes.